of who and what we are as a people is, I believe, one of the tremendous blessings that we're going to look back at 10 years from now and understand how we took this work and we expanded it to reach more robustly into the diversity of who and what we are as a people. Amy, next slide. I will say to y'all, I have been very much struck with thoughts of Mary McLeod Bethune over the course of the last month. And if you all do not know the significance and the work of Mother Bethune, I really encourage you to do some study. In my faith tradition, I am taught that faith comes by hearing. And your conversations, my opportunity to listen and hear you within each coalition and across coalitions, really affirms another element of my faith tradition, and that is that nothing is impossible. I'm going to just start with two of my favorite cartoons as a way of grounding us and preparing us for our keynote and the conversations that we'll have today. Many of you, because you have been around me forever, these are not going to be unfamiliar graphics. But this is the Finger Lakes region. This is the Finger Lakes region color-coded by poverty, by socioeconomic status, by measurements of education, income, social services dependency, joblessness. And as we think about who we are as a Finger Lakes region, as you all know, I start with the proposition that we have to dispel the fallacy that poverty is relegated to the heart of the city of Rochester. And we have to embrace the truth that poverty is the defining characteristic of our region. Notwithstanding the concentrated pockets of wealth, and we know where they are because we know the eastern suburbs of Monroe County. We know Northern Ontario and Livingston. We know those lake properties that dot our rural communities. But we know the truth, that those pockets of wealth are really the exception, and that poverty is the defining characteristic. And as the animation shows, if we take that same map and we tie it to premature death, what we absolutely know is that poverty is killing us. And as a result, we understand that all of our approaches towards health improvement, no, Amy, that's all right. You can go advance to the next slide. We know that all of our advances towards health improvement have to recognize the manner in which poverty is the limitation to individual and community health self-management. This is another one of my favorite slides because it shows that when we ask folks, how important is it to eat healthy? We see the Black and Latino community having an even higher value on healthy eating than their white counterparts. The challenge is it is very expensive to eat healthy, particularly after the income required to apply towards shelter and clothing and medicine and utilities gets applied. We have to deal with the reality that for our communities, folks have to live with too much month and not enough money. Next slide, Amy. And that's why you guys have been incredible partners. And as the CEO of an agency with a 4 decades long history needing to effectuate change. You all have been necessary supports for me as my colleagues and I, your staff, have been working to understand and advance the understanding that if we're really going to make a difference with regard to equitable outcomes at the downstream measurements of life expectancy and disease burden, that we're really going to need to make a difference in the upstream domains. And you all have been instrumental in helping us move from data to information to understanding, to really drive home the point that if we're gonna go further, faster with regard to health improvement and health equity, we need to focus on the living conditions of the folks in the Finger Lakes region. And that means that we have to boldly address structural inequity and social justice. And you all should feel incredibly proud of how very easy it was for us as a staff to lift to Common Ground Board's Common Ground Health's Board of Directors. And last spring, get a unanimous declaration from our agency board that yes, racism is a public health crisis. And so I welcome you here this morning, but I also am here to thank you. I am here to thank you for the way in which you have helped us make our work more meaningful at the street level here in the Finger Lakes, here in Monroe County, and here in the city of Rochester. This is another one of my favorite slides that I want you to know that I've been carrying around the community as I've been doing virtual presentations over the course of the last several years. This is a map of the city of Rochester, and it shows those red dots are the outlets in the city that have been approved by the state and the county for selling tobacco products. And it is important for us to note that the area represented is the home of only a quarter of the county's population, but it is the site of more than half of the outlets approved to sell tobacco. And so as we look at smoking rates, as we look at the recidivism in smoking cessation programs, it's important for us to have our focus not just on individual behavior, but on the systemic inequity of how it is that these outlets are disproportionately shoved onto the street corners of the neighborhoods in which we live. Amy, I also think it is incredibly important, and I have been sharing since I came across this data point last October, shared by the M&T Bank, their regional economist, took a look and shared in public space at the experience of this pandemic across wage sectors. And I think it is incredibly important that we understand how this pandemic has been an exacerbator of reality, not a creator of reality. And it is important that we tell the truth, that literally through this pandemic, the rich have gotten richer and the poor have gotten poorer. And so I am going to end my remarks. I just wanted to make it very, very clear how incredibly grateful I am that we are here for this year's Speak Life conference, building off the conference that we held in 2019. And I am teasing across the community as I go the fact that the African American Health Coalition and the Latino Health Coalition are going to be soon releasing the updates to their reports. I find it incredibly exciting that you all continue to speak truth to this community. And I promise you that we as Common Ground Health, your staff, will continue to aim to be a better amplifier, a better platform builder, and a closer partner to you in your efforts than ever before. Because quite honestly, you all are the folks who give me the energy, who give me the reinforcement, and who give me the love that enables me to continue to do the work that I do. Next slide. Staying with Sister Bethune, I am really, really excited for these reports to roll out because these reports and your work are just as essential to our recovery from the pandemic as are the vaccines. I'll just tease a bit for those of you all who have not seen some of the data that's forthcoming by sharing with you what I've been saying ever since we released the Overloaded report. Central to all of our work in the coming years will be addressing social and emotional and mental health. It is a great Chamber of Commerce data point that we can say that 90% of the adults who live in the Finger Lakes report that they have good, very good, or excellent mental and emotional health. But that means that 10% of our neighbors say that their mental and emotional health is at best fair, if not outright poor. And you all know the data is very clear that let's not talk about race and ethnicity. Let's just zero in on for those adults who live in households with an income less than $25,000 a year, who live in a neighborhood, be it urban, suburban, or rural, that they report is unsafe, and who tell us that they meet transportation barriers just to accomplish their daily tasks. That 10% becomes 54%. And this was pre-pandemic. And this is the adults only. There's an African proverb that says that in a wise village, the elders gather in the morning and in the evening and ask themselves the key question for the village's health. How are the children? And I would say to you, that is the area of work that we need to be focusing on. The last slide took a look at that same data point by race and ethnicity and showed the disparity Black to white. This slide shows very troubling. And I appreciate your work in pulling the data and understanding together that's showing us how the mental health crisis is deepening within the Latino community. But I want you to know I am not only a prisoner of hope, but I remain incredibly excited because every day I get to tune into what's going on in the local news, and I get to see Reverend Johnson or Dr. Conyers or Rudy Rivera, and I get to really see the coalitions are in incredible dynamic action, making a difference in this community and doing the essential job that's necessary in the face of illness, disease, and death. You all continue to speak life. Mother Bethune said, invest in the human soul. I want to encourage you all as we move forward. Let us be boldly a part of the conversation about how it is that we help the children in this community who have had their lives disrupted, not just by the pandemic, but also by a year's worth of living with and experiencing the disruption and the constant re-triggering of trauma in their lives, by the lived experience of all of the officer-involved murders and killings that have taken place in this nation, that have been made real for them by the experiences of Daniel Prude and by the little girl on Harris Street that was pepper sprayed, and by the video of the mom tackled by police officers with her baby in her hands. Let us remember that our most essential treasure is our children. Let us invest in every human soul. Who knows which of them might be a diamond in the rough. Thank you all so very much for your kind attention. I am so very delighted to be able to yield the floor and welcome next our keynote speaker, Dr. Kenyani Davis. Dr. Davis is the Chief Medical Officer of the Community Health Center of Buffalo. In this role, she has responsibility for ensuring that CHCB's providers provide safe, effective healthcare services to patients who are visiting the center's Buffalo, Cheektowaga, Lockport, and Niagara facilities. We all in our community have an incredible appreciation for the role of our community health centers. And we also, because we've had the chance to work with and love Dr. Linda Clark, we also know the incredible value of the CMOs of CHCs. And so I want you to know that Dr. Davis has already pursued and distinguished herself by building a career that is focused not just on clinical excellence, but also on community care. And she has brought to that career experience gained by working with Millennia Collaborative Care, which is the PPS over in the Buffalo community. And I am so doggone delighted that in the middle of all the incredible work that she does in our western suburb of Buffalo, that she would also find the time and she would also be gracious enough to come in and speak with us this morning. Please join me in extending a warm welcome to Dr. Kenyani S. Davis. Dr. Davis.
Thank you so much. Thank you, Mr. Norwood. I tell you what, with the introduction like that, I'm waiting for Dr. Davis to walk in the room because he can't be talking about little old me. But it is an honor and a pleasure to be here. I tell you what, when Dr. Clark calls, you just come running. That's how this works in this area. So one of the things, I got so much good stuff that I want to tell you guys. I see that we have interpreters. I'm from the West Coast, so I tend to talk really fast. So I'm going to try and slow it down. But I'm so excited to be here. So I want to try something really quick because I usually do this interactively and I do this in person. So we're going to try to still bring that same je ne sais quoi. There is a raise hand function. So I got a first question for you guys. Next slide. Next slide. That's okay. All right. So here's the question. Are there differences in health outcomes based on race? So I'm going to see people's hands. Who knows if there's a difference in health outcomes based on race? Okay, I see one hand. Anybody else? All right, I see another hand. Okay. So guess what? This is not that talk. I'm not here to convince you that there's differences in health outcomes based off of race, because from the looks of these hands, it looks like everybody else agrees, right? So what are we doing in this talk? In this particular talk, we're going to start to lay the foundation for you to start to think about health outcomes and health disparities a little differently. That way, you can start to think about how to put real solutions together so that you can think about these disparities and start to address them systematically and a little more thoughtfully. And one of the things that I think is so great, and Mr. Norwood eloquently talked about it in poverty, right? What is poverty and what is health outcomes? How did we get here? And that's what this talk is going to be about today. Next slide. So let's talk about health disparities. So I always like to level set to make sure we're all on the same page, right? So what is a health disparity? So according to the CDC, health disparities are preventable differences in the disease burden, injury, and violence, or the opportunities to achieve optimal health. And the reason why I like this definition is because if you underline that part, opportunities to achieve optimal health. So we're not just talking about the difference in hypertension and diabetes. We are talking about robbing you of your opportunity to even achieve the constitutional pursuit of happiness, right? That experienced by socially disadvantaged populations. So that's what a health disparity is. And so we're gonna sit on that as our operational definition. Next slide. Now, keep in mind that populations can be defined as either race and ethnicity, gender, economic, education, geographic areas. So a population can be defined however you want, but it's robbing that population of that opportunity. Next slide. So when we think about health disparities, they are inequitable and they're directly related to historical and current unequal distribution of social, political, economic, and environmental resources. Next part's on the slide. And the reason why that's important is because I want you to think about COVID. Think about the context of COVID. I just got done saying health disparities are created by social, political, economic, and environmental resources. So let's talk about the vaccine distribution rollout, right? That was political, right? Who got the vaccines? Where did you get the vaccines from? Did you get them from the state? Did you get them from the federal government? In the middle of a pandemic, that African Americans were dying 2 to 3 times more likely than their counterparts, which happened to be white. However, they were vaccinated at a much lower rate. So think about that. Also, when we think about at the very beginning of this last year, when we talk about New York, we talk about New York City, and we talk about all around the people who were getting infected. At one point, some people tried to sell you the notion that genetically underrepresented minorities, there was just something different about them that made them more susceptible, which is not true. Think about the economic and the social part. Underrepresented minorities tended to hold the jobs that were most likely put them in harm's way most of the time. Some of them were hourly workers, not salary workers. So we couldn't sit and take PTO and just sit off in our cushy little houses and just wait it out. So health disparities is an unequal distribution of resources. Next slide. So you hear this thing called health inequities. So then what is health inequities, right? If I just told you health disparities were these systematic differences, right? Next bullet point. Health disparities and health inequities are just simply the differences in the presence of disease, health outcomes, or any access to any healthcare between any population groups, right? Next bullet point. But there is a difference between the two. Even though they have the same last name, there is a difference. And here is where I'd like to make the case that COVID is actually a health disparity on top of a health inequity. That sounds really smart, right? So let's drive that home and see really what in the world is this crazy Dr. Davis talking about COVID being a health disparity on top of a health inequity, right? So health disparities, right? Differences in outcomes based off of diseases, next bullet point. Health inequities, however, right? Next slide, or next bullet point. It's the same thing, but the difference is that health inequities are unfair and they're unjust. Sit on that. Health inequities are unfair and unjust. That means something, someone, or somewhere, something unfair or unjust happened. It didn't happen by accident. This unfair and unjust portion is usually rooted in social injustices that make some population groups more vulnerable to poorer health than other groups. Going back to what I was saying, African Americans are 2 to 3 times more likely to die from COVID and least likely to be vaccinated. COVID, a health disparity. Nobody said, I'm going to make COVID and just throw it at the world. But it's a disparity that lies on top of the health inequity. Next slide. So then what's health equity and what's health equality, right? I like to give it in this example, right? I'm a shoe fanatic, right? So back in the day, I used to collect Jordans, right? That was like my thing. But when you grow up in areas like I grew up, people weren't getting cars at 16. We were getting shoes, and that's about it, right? So Air Jordans, Louis Vuittons, Tom Ford shoes, whatever it is that you like, right? I wear a size 9. Everybody on this call, I can see there's about 60 people on this call. I'm going to give everybody a size 9 in Air Jordans or Louis Vuittons. Raise your hand if you're a size 9. I see a few. Okay. So it's about only one of you guys can benefit from this. But the rest of you guys can't because you don't wear a size 9. So that's the difference between health equity and health equality. Health equality, I give everybody the same thing. However, the problem is there's obstacles and I can't get to it. Health equity is, I would take a survey and say, what size Jordan are you? What size Louis Vuittons are you? What size Tom Ford shoe are you? And whatever you are, I'd mail it to you. I'd give it to you. That is removing the obstacle. Now, that's a pretty superficial way of looking at it. But when you take it a little further, those obstacles, the shoe size is really poverty. The shoe size is really discrimination. The result, you not being able to get to, is the consequences of those barriers. So when you think about equitable vaccine distribution, right? When this rollout first came out, you had to be 65 and over, right? In order to get your vaccine. How were you supposed to sign up for it? On the internet. You were supposed to go onto that wonderful CDMS website that, in my opinion, never really worked. I was supposed to tell my 82-year-old grandmother, who doesn't even have Wi-Fi, to log onto the computer and sit there and try and get a vaccine. Now, why that's important is because let's talk about obstacles. Let's talk about equitable vaccine distribution in the midst of COVID for the people who are hit the hardest. So sometimes these barriers, these obstacles that we create, sometimes they're known, sometimes they're not known, but we have to start to think about more equity instead of equality. Just because I give everybody something doesn't mean they can actually access it. The other notion is, when we were talking about COVID and we were talking about vaccines and treatments, hospitals have the vaccines. When you do get COVID, you go to a hospital. Inside of underrepresented groups, mistrust is a huge factor. So let's talk about equity. I'm telling people who have mistrust, who have different engagements and different experiences in hospital settings, that if you get sick, I need you to go to this place where you already feel unwelcomed, and a place that you already feel like there's a systematic difference in how you're treated. And we're going to talk about that a little bit more. And then we sit around and say, I don't know why they just don't go. I don't know. I just don't understand. It's there for them. They have access. All they have to do is just walk through the door. Obstacles, health equity. Next slide. I love this. Next slide. I love this picture because it really puts everything that I was talking about into context, right? Equality versus equity versus reality. And it's like Mr. Norwood said, you know, the rich get richer and the poor get poorer, and this pandemic exacerbated that issue. Next slide. Now, my favorite topic in the world, social determinants of health. People ask me this all the time. What is social determinants of health? Next slide. Social determinants of health are all of the non-medical things that contribute to somebody's health. And when you look at this lovely infographic, what I love about it is in this person, you can see that only 20% of somebody's total health and health outcomes is rooted in healthcare. It's rooted in what I do for 15 minutes in a room every single day. However, every time people talk about health and health outcomes, they always talk about, let's get them to the doctors. If these doctors just check this. But here's where this conversation happens. Here's what today's talk is. I want you to change the lens in what you think about health. It's not about what I do for 15 minutes in the room every day, because I only affect 20%. 80% of somebody's total health is based off of things like socioeconomic factors, physical environments, health behaviors. So when you're really thinking about somebody's diabetes or hypertension, is it really what I do, or is it based off of these other factors? Next slide. So let's dive into this a little bit further, and let's put this in the context of COVID. Next slide. Healthy People 2020 put a framework together to start to talk about social determinants of health, and they put it into 5 different categories. Those categories being economic stability, education, social and community context, health and healthcare, neighborhood, and built environment. So what does that mean? When you talk about economic stability, you're talking about employment, food insecurity, housing insecurity, poverty. Here comes that word again. Education, you're talking about K through 12 education, right? Why that's important is because in the midst of COVID, what did we do? We closed the schools down, right? Schools that were in the inner city had a more difficult time of opening up. Who goes to those schools in the inner city? Mostly Black and brown students. We know that a white male with no college education can get a job quicker than a Black male with a college education. So in the midst of COVID, we've shut schools down. And I'm not saying that we should open them all up, but we have to do it in a safe way. But think about that. That is a social determinant of health. Not one that you're going to see tomorrow, but one that you're going to see in the next generations. Employment. Highest records of unemployment. Housing insecurity. We're going to talk a little bit about housing, so I'm going to put a pin in that. Social and community context. Mental health. So excited that Mr. Norwood talked about this. Mental health in the minority population is such a taboo topic. However, what this pandemic did was threw more toxic stress onto this community. The George Floyd trial that just happened, we've been through trials before, more stress, more tension. People who have not had mental health issues are now starting to see mental health. And that had nothing to do with the 15 minutes that I do in the room every day, and everything to do with the 80% of those social determinants of health. The other part is, let's talk about housing really quick. So let's go to the next slide. So let's focus on the built environment so that we can start to really dive in to that next slide. Next slide. We're going to start to talk about the elephant. Nobody likes to talk about the elephant, that poor elephant, but we're going to start talking about it. Next slide. So Rochester, let's look at your map. Next slide. So let's talk about this map. So let me give you a little context. In 1930, about a fifth of the country was unemployed. Sound a little familiar here? So President Roosevelt said, you know, we gotta do something. So we have to beef up the middle class. We have to do something. So they had record low interest rates, and they said, you know what? We are going to allow people to get a housing, safe housing. So let's talk about this. 1930, they knew that proper built environments and safe housing was important. It was important not only economically, it was also important for America to thrive. So they started to give these loans out, right? And if my history buffs out there, so this is where we got our suburban flight, right? So this is when people started to move out and start to build these white picket fence with the 2.5 kids and the dog. But guess who was excluded from that? People who look like me, people who look like some of you. Some of these loans actually had covenants in it that basically said, you cannot give these mortgages to Black people. They cannot move in these particular areas. And why that's important is because it created a map called redlining. In Rochester, this is your guys' map for redlining. And what's so important about this redlining map is that this still continued for a really long time. When I mean a really long time, I'm talking about decades. And if you take this map and overlay it on top of the map that Mr. Norwood had talked about, these are your areas that still have lower socioeconomic status. These are your areas that still have increased COVID rates. You are still reaping the consequences of something that happened decades ago. Research has shown to undo this wrong, it takes 7 generations. Do you know what 7 generations equals? 7 generation equals 200 years. Sit on that. I'll wait. Probably be dead by the time they write that wrong, but 7 generations. The other thing that's also in there, when we talk about poverty, we talk about food insecurities. What does that mean? Food insecurities means waking up and not knowing where your next meal is going to be, or just not having enough money to afford food or the right types of food. Food deserts, not even having access. Let me tell you something. So I live in Williamsville, which is a middle-class neighborhood. I've got about 7 grocery stores within walking distance. But where I work, there's only 1. 7, and I don't even cook. 7 grocery stores, but they only have 1. Why is that important? Because the rates of diabetes where I work are through the roof. The rate of African Americans and Latinos being hospitalized due to diabetes, Blacks were 354 per 10,000 being hospitalized. Latinos, you weren't too far behind us. Whites, 54. Food insecurities. I know that people with diabetes, almost 16% of them have food insecurities when they have uncontrolled diabetes. They happen to live within that redlined area right there. Next slide. I'm gonna get off my soapbox because I got so much stuff that I want to tell you guys. So why does this happen? Because medical community, we talk about diabetes, we got to control this, cardiovascular disease, people dying of heart attacks and stroke. What are we doing here? Is it race? Is race a factor? So you know what? My community, my medical community, as doctors said, you know what? Let's take a look at this, right? Because the only thing we know is we know stats and we know randomized control trials and gold standards and stats and numbers. So the Institute of Medicine, which is like the Mecca, said, you know what? In 2002 of March, let's do this revolutionary report and let's just examine this and see if there's any utility in what these people are talking about. Next slide. You know what they found? They found that there were actual differences in outcomes from the beginning of life to the end of life more specifically based off of race. That was 2002. And what's so unique about this is when this first came out, this was like, oh no, not us. We could never be contributing to such stuff. But you know what? The one thing that it failed to do was actually call a spade what a spade was, that race played a part. Despite having data that backed up everything that we were saying, it lightly said, you know what? These African Americans are really experiencing these disparities from the beginning of life to the end of life, and that's so unfortunate. But you know what? We're going to break them in these three different categories of clinical uncertainty and stereotypical behavior and biases, right? And this isn't the focus of the talk. But the real thing is that it failed to call a spade a spade. Next slide. So they even showed that cardiovascular disease, right? That African Americans were least likely given life-saving options such as bypass surgery, right? And that still wasn't enough to call a spade a spade. But what they did find is that these factors that contributed to the disparities happened at many different layers. The health system levels, the patient level factors. So it became a structural thing. Next slide. Next slide. Next slide. Next slide. So what is race? Next slide. Race is a construct. When I walked in the room, you saw a Black female. You didn't see Dr. Davis until they told you. That's okay, but it's about what comes after that. It's really what matters. Next slide. Racism inside of our literature started to be talked about in a roundabout fashion, right? But we never directly said that race was the cause of any of this, right? We knew mistrust was something that happened in the health community, but we never said race was a social determinant of health. Race was what dictated your health outcome. We knew that zip codes mattered, but we would never see race determined your health next outcome. So when we talk about race, we talk about race in many different levels, at the patient level as well as on a system level. Next slide. So in public health, we looked in 2018 and we said, you know what, does race play any type of role? Looked at every type of literature in 2018 and we said, it may, but we still never called a spade a spade. Next slide. So let's move to Black women and reproductive health, because we're going to start talking about the elephant in the room, racism. Racism. So I want to show this context in the context of maternal mortality, because I want you to see all of these aspects kind of go together. Okay, we're talking about macroaggressions and microaggressions. These are the little things that nip at you all day long, right? Next slide. Next slide. Let's jump to Black women and reproductive health. Let's pass this. All right, next slide. So let's level set. In 2017, I just want to make the context of how this isn't new. Black America, infant mortality, so any baby dying within the first year of death, was 11.5 per 1,000 births, compared to white America, which was 5.2. Sit on that. Next slide. We're talking about systematic differences. Systematic differences. So let's talk about Rochester. Let's talk about you guys here in Monroe County. Oh, it's the same thing. Sorry, guys. Thought I had something good to say, but it's the same thing. Rochester, you guys are actually 12.5 for Blacks. Latinos, about 5.3. Monroe suburbs, 9.3. So you say, even though we're in the suburbs, so you're saying that Black women are still dying, infant mortality is still high. Interesting. Next slide. So what about over time? Nope, still same thing, still higher. Next slide. Maternal mortality, just as dismal as infant mortality. Next slide. But what's interesting about maternal mortality is you see this thing, racism, they start to talk about racism being a social determinant of health as to why some of those things are staggering. Because I just got to telling you that even regardless of socioeconomic status, whether you live in the suburbs or you live in poverty, that rate still existed. Next slide. Birthed a new terminology called weathering. Weathering, what is weathering? Dr. Geronimus in 1992 started to formulate this hypothesis that all the wear and tear and microaggressions and stresses that people have start to wear on their DNA and actually start to make them older than what they really are. Interesting concept. Next slide. So why do we even care about that? Because, next slide, what we found was that even across all socioeconomic statuses, by middle age, there's significant racial differences in chronic morbidity and excess mortality across all socioeconomic statuses. Next slide. What that translates to is that the DNA of African American women are 7.5 years older than white women of the same age. Sit there. So if you're really 35 years old, me, then that means I'd be 42 years old. My DNA, my body, just based off of my interactions with my environment, ages me 7.5 years. Just being Black in America ages me 7.5 years, and we wonder why these health disparities exist. Next slide. And when we talk about systematic differences, African American women are 3 to 4 times more likely to die during childbirth. In 2013, actually, the CDC for pregnancy-related mortality, so we're talking about not dying during childbirth, but at least after childbirth, 12.7 per 100,000 was the number. African Americans were triple that. Such a complex problem. Next slide. Let's go to Dr. Shalon Irving and do this really quick. She's a 36-year-old African-American female, lieutenant commander of the U.S. Public Health Services Commission Corps, and a CDC epidemiologist with a dual doctorate in sociology and gerontology. It's a smart woman, y'all. She had a wonderful, beautiful baby, and she died 3 weeks after giving birth. Not her. She's from the CDC. Not her. But she died. She even went back to the doctor and said, I don't feel right. But she still died. She suffered from complications from blood pressure and actually ultimately died from a blood clot. And when we talk about the 3 causes of maternal mortality, all 3 of those are up there, but we're going to sit there. And in my opinion, what all of this means is that the most dangerous place for a Black woman happens to be in a hospital. The most dangerous place for a Black man happens to be in the streets. This is what stats tell me. This isn't my thoughts. This is what America has told me so far. But why this is also important for making the case that COVID is a health disparity amidst a health inequity. Just 2 weeks ago, the CDC finally said, you know what? Racism is a serious public health threat to America and acknowledges something that researchers have found for decades. That was 2 weeks ago. They finally said racism is a public health threat. The CDC. Finally, even after their own died. Next slide. So let's talk about COVID. Next slide. Remember those five social determinants of health. So when we look at rates of hospitalizations and death based off of Rochester in general, when we look at Black, just look at the colors, Black, and we're still higher. These are trends. Next slide. When we look at who's going to die, the systematic differences, my race makes me twice as likely more than whites to die. It has nothing to do with my genetic composition. Nothing, just my race. Next slide. When we look at rates, when we look at the rates of contracting COVID, look at that. Your race is a social determinant of health for you contracting COVID, just your race, not your socioeconomic status. Next slide. So let's talk about hospitalizations now. Next slide. Guess what? Your race dictates and determines your likelihood of hospitalizations. Now, we can get all the way into these particular talks, but that would be a whole nother conversation. You have to bring me back for that one. Next slide. What about death rates? What about death rates? Oh my gosh, it looks the same. COVID is a health disparity put on top of a health inequity. What that means is whether you have COVID, ROVID, SOVID, LOVID, whatever you want to call it, you will have the same color context in here because race is a social determinant of health. And until you fix the health inequities, you will never fix the health disparities. Next slide. Black and Hispanic, twice as likely to die from COVID-19. Now, if I moved COVID-19 and put anything there, this graph is still going to look the same. So I'm going to wrap this up. And I thank you guys for your attention and me talking super fast. But really what I want you to understand is finally, race is considered a social determinant of health. Meaning just as much as smoking, just as much as obesity, just as much as cardiovascular disease, your race determines your health. So when you start to go into your breakout sessions and start to think about how do you address that, you can't change race because it is a social construct, meaning it has no meaning. We place meaning on it. So when you start to think about your solutions, I want you to think about race as a social determinant of health and race as a social construct. What meaning are you going to put into race? And how are you going to start to forge the solutions on how you will start to create health equality? Thank you guys. Thank you for your time.
Wow. Wow. Dr. Davis, that was powerful, poignant, and on time. And it's going to take me a few weeks to digest all of that. So let me thank you in advance for two things. One, thank you for not watering down these issues and being so direct and transparent about this. And secondly, let me thank you in advance for already agreeing to transplant and transition your life here to Rochester, where we can use you a whole lot. So thanks in advance for doing that. That is wonderful.
I'm always an ally.
we have a few questions. I know we only have a little bit of time, and I want to start this and ask you to briefly answer this. You spoke to us and you set the tone when you gave us a context for inequities, and you stated that we should know that it is the unequal distribution of resources. Given that the context for the whole discussion is what happens when inequities occur. What do you think is the biggest issue leading to the current climate and situation? Is it those who are afraid of the redistribution of wealth, or is it the inability of others to recognize humanity? What do you think?
That's a good one. I would say it's the inability to recognize humanity, right? The thing I always say is if you ever wanted to, if I could choose one thing to fix all of this, it would be to improve the education system, right? Education increases your chances of financial security, which moves you out of certain things. Education, even if we're not talking about moving people out of certain situations, it broadens your horizon, right? That is the reason why the education system is heavily guarded, right? It's heavily guarded for a reason. And then, like I said, it takes about 200 years to right some of these wrongs. So when we think about, inequalities, and we think about that, think about the education system. Think about what that really means. The most powerful thing you can have is an education, right? We can't take it from you.
Wow. So there's a question, and I'll kind of combine a little bit of a comment. Sadly, we got in our chat that Ms. Teresa Harris recounted an event of mistrust and her constant battle that unfortunately is not unfamiliar with persons of color, and her battle with both law enforcement and the medical community. And so I want to, in light of that, and I invite Ms. Harris to speak a little bit more of that later in some of our breakouts. But in light of that, the question is asked also, given the mistrust level in the medical system, what are your thoughts on improving the rate of vaccinations in the Black and Latino communities?
You remove the barriers, right? And I've been a big component of, for Black and Brown communities, we are educated people. We know ourselves. Give us the right education on X, Y, and Z the right way, and let us make an informed decision, right? That's the thing. Just because you put a little Black girl up there and say, hey, get the vaccine, right? That doesn't work. The dog and pony show doesn't work, right? Give us the same information that you give the people who live in the waterfront. Remove the same barriers, remove those barriers, right? There is vaccine hesitancy, absolutely, but we're ready to get it. You just have to remove those barriers and meet us where we're at, right? And I think that's the difference, right? I think that in some areas they're coached, right? And we're just told. And that's the difference. You got to talk to people, not at people. You know, majority of communication is nonverbal, right? We feel that. And that is where we have to be at. And when we talk about COVID, we talk about vaccinations and decreasing that disparity, talk to us, not at us.
Wow. You know, for a lot of faith-based organizations and community-based organizations, we give a lot of hyperbole about barriers, but oftentimes we don't truly understand what it takes to remove those barriers. So the question comes from Dr. Conyers. Could you help us to understand what CHCB has done to address the disparities and inequities that you spoke of during this pandemic?
Absolutely, that's a great question. It's been a 24/7 operation. When we started, when 65 and overs had to be on the internet, we literally put an entire call center together and said, you know what, just call us. We will get online for you, whether you're our patient or not our patient. We actually went out into the community and educated people and talked to them and not at them. We partnered with community-based organizations and faith groups, and we actually started going in and doing pop-up vaccinations within churches. So we removed the mistrust. We said, don't trust the medical community. You trust your church, you trust your pastor. We are just an extension of him or her. And one of the things we did is we went into we're already in the community, so we didn't really have some of the similar problems that other people did, but we didn't come in the community to use the community. We came in the community to see what type of resources they had, and we were just there as supporting cast members. And a lot of times in the medical community, we don't want to be supporting cast members, right? We want to be the starlet. And we took a totally different approach. We were the supporting cast member in this.
Wow. You said something so powerful. It just made me stand still, and it gave me pause when you said the greatest threat to the Black woman is the hospital, and to the Black man is the streets. And so it dawns on me that both of these, it's not the street lights nor is it the building, but it's the encounter. And one of your slides spoke of the disparities arising from clinical encounters. And I suppose we can say law enforcement encounters also. Can you help us, in your opinion, to imagine how we may be able to advocate for ourselves in the clinical setting? My supposition is that we probably can translate that over into the street setting as well. But how would we advocate for ourselves in the clinical setting?
Yeah, absolutely. Keep asking questions. I tell my patients all the time, you hurt no one by not asking questions. And a lot of my older minority patients are like, oh, well, it's the doctor and I don't want to offend them. For what? For what? Right? Finding a doctor is like finding your mate, right? The first doctor you see just because they wear a white coat may not be for you, right? You have the right to advocate for yourself. You have the right to ask a question. And if anybody is making you feel like you can't do that, keep asking them, because trust me, somebody's going to come down. and answer that question. Continue to advocate for yourself. Continue to educate yourself on your civic laws, right? The laws that govern. Continue to vote. You don't like the way you're treated in the streets? Vote your mayor out. Vote your governor out. Vote your city councilman out. Get the right one. You have more power than you think you have. Don't let anybody take that away from you.
Wow. I mean, I think we all just have those stories, and thank you for saying that, because it is true. We often don't realize that we can advocate for ourselves, that we have a voice and we have agency in our own healthcare, in clinical settings, and on the street. And so let me ask this, the weathering of the Black woman. Have you found any data that shows the weathering of Black and brown males?
No, I have not, but we should do that research study. So maybe that's how I get to Rochester. We do that study. But no, that is an amazing question. Let me tell you something. The Black man is actually a very forgotten group, right? Don't tell my husband I said that, because then he's going to say that his experiences are worse than mine. But it's actually a forgotten group, and it should be on the extinction list, if you ask me, right? And I think it's a very important topic. And I think that as people go out in their breakout sessions, thinking about that, what is the loss of impact to society if the Black man is not present?
Wow.
Right.
Yeah. So one final question I'll ask here, because it's easy sometimes to forget that this is a big fight. And it's also difficult not to dilute the nature of this fight. So what would you say should be the partnership, the agreement, the terms upon which both Black African-American communities and Latinx, Latino communities get together and co-advocate against all of these issues?
To not fall victim to separation, right? You divide and conquer. We are all of the same blood. We are all in this fight together, and we can't do this alone, right? You have to have allies. I have to have my white allies. I have to have my Hispanic allies. We don't do this alone, because really what we're fighting for is equity. And that's a human thing, right? So we're all fighting for the same common ground. And I think one of the things is to not really focus on the differences, because the truth is we don't have that many differences. And when we talk about our DNA, it's all the same. So that's what we need to focus on, making sure that we do not get divided, we do not get segregated, and we stay on the same core common grounds. That is how we get past all of this. And understand that it's okay. It's okay to agree to disagree. We don't have to believe in the same thing or how to get there. We need to believe in the same goal and the same mission.
Wow. Thank you for that. That time has come, and I just asked Dr. Davis if you have any parting advice for us before you pack your bags and head this direction. If you have any final words, will you take about 30 seconds and share them with us?
The only thing is that I am honored to be in this fight with you guys, and that at the end of the day, I am hopeful that we will get past this, but we have to ensure that we put together actionable, real things, and we will find solutions to these. You're going to get tired, but with the strength of God, you continue to move your feet. Even if you don't know where you're moving them, just move them. He'll order your steps.
Wow. Thank you so very much, and God bless you, Dr. Davis. We're just excited for what you've shared with us today, and we can't wait to continue this collaboration. Thank you so very much.
Absolutely. Thank you for having me.
Thank you. Brothers and sisters, we're grateful for the presentation. We're going to move on now, and I'm excited about this. We're going to put on the screen a poll for you. And we'd like you to complete this 3-question poll. And we're going to take about 5 minutes as you complete the poll. We'll take about 5 minutes, and we will return at 10:21 to continue our conversation. Thank you so much. All right, it's that time to continue and move forward on into our presentation and our ceremony, I will call it today. This has been power packed so far. We've done this thing in terms of Speak Life for a number of years, and we've tried to bring out the point that health really is a spiritual matter. And there have been a number of individuals who've been doing this work throughout the community. And it's time now that we recognize one such individual who has been doing the work. And so I'd like to bring up Dr. Linda Clark, Chief Medical Officer of Common Ground Health, to present this year's Faith and Medicine Award. Dr. Clark.
I'm sorry, I'm muted. Good morning, everyone. I am really excited to speak about this Faith and Medicine Award. It is given annually to an individual who has impacted the health of racial and ethnic minorities in the 9-county Finger Lakes region served by the African American and Latino Health Coalitions. It is named after the late Reverend Dr. Weldon Thomas, one of the champions of the link between health and the spirit. Health professionals awarded this honor believe that health is impacted by spirituality and faith, and vice versa, and actively work in our community to impact both. This year's recipient embodies those principles, and she is the first to tell you that health is a spiritual matter. She is the Community Wellness Project Manager for Common Ground Health, the founder of the Interdenominational Health Ministry Coalition, and leads Renewing of the Mind, a mental health education training program. She is both an ordained minister and a registered nurse, and she is my dear friend and colleague, the Reverend Phyllis Jackson. And I do have a plaque, and I will put a picture up, but I think this one looks better. The plaque reads, the Reverend Dr. Weldon Thomas Faith and Medicine Award, Reverend Phyllis Jackson, RN, 2021. When faith in God is put together with medical knowledge, disparities are erased. It is my distinct pleasure to award this honor to Reverend Phyllis Jackson. And I think we're going to ask Phyllis if she wouldn't mind saying a word or two. Although sometimes a word or two is hard. Is she on the line? Okay, I don't think she's here right now, but we all join together in thanking her for her tireless efforts in our community. Thank you.
On behalf of Reverend Phyllis Jackson, I'd like to thank you for this generous award and acknowledging all of her efforts in the community. She has been a stellar advocate for so many inequities and for championing healthcare and better health outcomes among Black and Brown folks. And we do thank Reverend Phyllis Jackson for all that she has done, and we honor her. Thank you for that. Moving along now, here's a part that we want you to take part in and be an active agent in discussion with. Firstly, we're going to bring up Julio Jordan, Director of Diversity, Equity, and Inclusion at Ibero-American Action League, who will give you directions and lead you further in how we'll go into our breakout discussions. And Julio will also frame those discussions that we'll be having. My friend Julio, the floor is yours.
Thank you, and good morning to everyone. I am so happy to be here with you all, and all of the information and all of the speakers and everyone that has really shared with us this morning. The information, even though we know it, it resonates, and the reality of it is that sometimes you have to hear the same thing over and over again to really get it. And I'm thankful that our community is at that point. We've heard so far terms like redlining, inequities. I love the because I'm also a Jordan fanatic, not only because my last name is Jordan, but I've been buying Jordan sneakers since I was 13, since they came out pretty much. And I loved the analogy that was brought about where, if everyone gets a size 9, but not everyone wears a size 9, it's not really going to work. You know, you'll have a nice pair of sneakers to look at, to give away, to possibly sell, but they're not going to benefit you directly at that moment. So I want to share with you before we go into the next activity, you know, we know that there are a lot of inequities. We know, especially when we talk about COVID in our community, we know that we, Latinos, African American, Indigenous, we are more likely to pass away, to be affected in a very negative fashion by COVID. We know that, and one of the things that I see now is that we are also the least likely to be given the vaccination or have the opportunity. You know, so I am beyond proud to be with an organization like Ibero, who, as of last Thursday and the next Thursday coming up, will be administering these vaccines to the community, because it's something that we have to make sure that, you know, we don't expect people to be able to make it to the hospital or to the doctor's office. We need to be able to have locations that are in the community right there. Father Tracy Center is another great institution right on Clinton Avenue that has done a great job of administering these vaccines as well. And, you know, we know that not everybody has Wi-Fi. We know that not everyone has the privilege of having a car, to have money to pay for gas, or to do any of those things. So sometimes, you know, having within the community that people could easily get to and travel to is important. But I also want to talk about one thing, and I'll wrap this up in a couple of minutes. When we look at, you know, some of the inequities that we face, we have to take a hard look at ourselves and say, what are we doing? What are we doing to move it forward? You know, and I'm going to use myself as an example. When the COVID vaccine trials started going full swing, I raised my hand and I was like, hey, you know what? I'll be a guinea pig. I know the history. Trust me, I know the history in Puerto Rico. I also know the history within the African American community where these trials and experiments were performed on human beings under the guise that it was to help, and in all reality, it was not to help. I understand that and I get that, but I cannot allow the mistrust of what others have done or the fact that others have misused our trust. I can't allow that to be the reason why I don't contribute and do what I have to do. So I signed up for the vaccine trial, the Johnson and Johnson one, really without a complete understanding of what could happen and not really worrying, because honestly, I'm walking by faith. I'm not walking by sight. You know, there's so many things that could basically be put in front of me or that people can tell me that'll stop me from doing that. But I know that as a Latino, a 45-year-old Latino male, we are less likely to subscribe or partake in these types of trials. So there's no way that I can talk to a brother of mine, a friend of mine, a colleague of mine, and tell them, hey, this is safe. This is something that's important, without me doing it first. That to me holds a lot more weight. So instead of talking about something, I'm actually doing it and showing it. So I just challenge each and every one in our community to really, you know, look at these inequities, look at these challenges that we're facing. And I like to refer to the fact that, you know, we've just been hitting the snooze button for decades. And now it's time to stop hitting the snooze button, and it's time to act on what we already know. We need to make change systemically within ourselves. So I challenge each and every one of you to just ask yourself, what can you do now that we know the information is in front of us? It's more in your face than it's ever been. Is what are you going to do to push it forward, to make sure that these changes are being enacted so that generations from now, we can have those, you know, equitable and fair rights. So just want to leave you on that, just a thought, but I thank you. And what we're going to be doing now is in a few moments, you're going to be placed in a breakout room. The goal of these breakout rooms is to have a discussion around solutions for the community. As a group, you will be tasked with one question to discuss for 15 minutes. We ask that one person volunteer to be a scribe And I would ask that you don't spend the 15 minutes trying to figure out who that scribe is going to be. So try to just have volunteer, take that charge. At the end of the discussion, you will be asked to submit one action item to share with the larger group. Your questions, your notes, and the final submission will be completed using a Google form that will be placed in the chat once you are in your breakout room. So you'll see that in the chat, in your breakout rooms. You will also get instructions as to which question you will be answering. But once again, I just want to reiterate, you're going to have 1 minute to present your action item. So please be concise. Please keep it to 1 minute or less. Aim for 30 seconds, so that way you'll end up at a minute. But we're going to, at this time, move you all into your breakout rooms. So we'll see you back here pretty soon. Talked about it, we discussed prior to going into the breakout rooms, and I'm hoping that you were able to really share and get through the questions. But what we're going to do is we're going to request that the scribe from each group share their one action item. Please be very concise for the sake of time. We want to get you out of here so that way you can get to lunch or brunch or whatever it may be. So limit it to the 1 minute to share. Be short and concise in your report. And then we'll start off with group number 1. So group number 1.
Julio, I think that's me. I didn't realize we had group numbers.
Yeah, I think everybody, when they broke in, was given like you're being assigned to group, but I honestly
didn't see that. That's okay. I'm just actually gonna then share access to policymakers and change the policies and procedures. So making sure that we're at the table for our voices to be heard, but also not just there as a quota, but to have an equal voice at the table and have fairly access, be more accessible fairly across the board. That's it. Thank you.
Perfect. Group number 2.
Jason, that's us.
And
I know I have to speak too. I apologize. That put me on the spot for real. Okay. Basically, our main thought out of this was that we need to be more in the street and increase our relationships with our community in general. So yeah, I was. Is that right to the point for you?
That's right to the point. We love it. Thank you. Thank you. Group number 3.
Let me unmute myself. I believe we are group number 3, if that was the question for who and what heals you. Is that correct?
That's us.
Okay, that's us. Just making sure.
Yeah.
So we came up with a few things. The common thread was knowledge and education was a tool for healing. We also had a lot of discussion about storytelling. People realize the importance of retelling the story, bearing witness, regardless of how exhausting it is, experiencing the trauma over and over again. But it's a necessary evil, so to speak. And what was the other piece we had? Strategically advancing conversations toward real solutions and punitive next steps to ensure accountability. And allowing people to heal at their own pace, whether it's in the faith community, support groups, professional care, etc. I think I captured everything.
That's perfect, Deborah. Thank you.
Welcome.
Group number 4.
Is that the last group, Julio? I think we got our numbers confused.
Yeah, you know what? Just to so that way we don't spend so much time, go right ahead.
Okay, awesome. So we had the same question as Deborah. So for us, it was really about how do we allow people to have self-determination, and as service systems, how do we listen and support and allow people to heal themselves with the resources that they need.
Perfect. Thank you very much for sharing, and we'll move on to the next group.
I think we're the last ones.
I had another group too, so I'll go after you, Francesca.
Oh, sorry, I didn't see. So we said a lot of the same things that have already been said, but our question was, how do we build back better after the pandemic? And so we're the fourth answer here. So we talked about, the one that we chose to highlight was integrating what we learned during the pandemic, and I would add to this, all of the inequities that we discovered and all of the sort of issues with service delivery. So apply what we learned, and allow communities to have input, much more significant input in decision making. For example, like how we sort of had to rally around the vaccine distribution, like doing that except with other kinds of services. Yeah.
Perfect. Perfect. Thank you. I know that we were group number 6. That much I do know. So Florence, if you want to go ahead.
Sure. Our question centered around trauma and how we are able to support our healers in the community, ways that we're able to recognize trauma and how we deal with it ourselves. As far as supporting our healers, we said that, we wanted to make sure that we knew that we are there for them, being able to support them however they need to be helped. And we wanted to also say that we wanted to be, as a community, not afraid to not only talk about our successes, but also be transparent and share our struggles as well, and how we can work together to, work on those challenges and be united in that.
Perfect. All right, next group number 7.
I'm not sure if we're group number 7, but I can go next, Julio.
Go ahead.
So we were answering question number 1, and we discussed lack of equality and how we might have access, but there are barriers, right, that are not acknowledged. We discussed one example of a specific child that was racially profiled by one of his teachers. We talked about we need to speak up. We have to be able to advocate for ourselves. But the other piece is that we want people to know that discrimination and racism is impacting our morality, our health, our lives. And in essence, racial inequalities affect our minds and our bodies, which is, the whole discussion we've been having. And then as an action item, we have to look at people who do not look like us and expand the conversation and see what others outside of the Black and Brown community are saying about this, because at the end of the day, it impacts us all. And so we have to make sure that we're having this conversation, as a community as well.
Perfect. Perfect. Is there anyone else? I know that we have, it looks like 5 responses there, but I know that we had more groups than that. So I want to make sure that we're all seen and heard. Anyone else that has not shared yet and is described for their group? I just want to make sure I'm not missing anyone. Speak now or forever hold your peace. All right. So thank you all for sharing. And these are things that we definitely, we'll take back not only to the coalitions, but hopefully you all can learn something from this and take this back to your own, your own little world, because I know that we impact each other's little worlds. It'll make our entire world a much better place. So we want to thank you everyone for sharing this morning with us. And next, I am proud and blessed to introduce Minister Green. Minister Earl Green is the Director of Family Engagement and Equity for the Children's Institute. In this role, he plans and improves activities that advance the Children's Institute's racial and social justice, family engagement, and equity initiatives to promote holistic well-being in children. So with no further ado, Minister Green, friend and community member, the stage is yours, sir.
Thank you so much, Julio. I appreciate that introduction and welcome everyone. And I am so privileged, feel privileged to be here to share this great event with you. And I appreciate so much all that we have experienced here so far. And I cannot say enough about the great job that Reverend Johnson is doing, as well as our keynote speaker, who spoke so eloquently on the issues at hand and her willingness to be unapologetic in her approach. So I truly appreciate that. I just wanted to share just a little bit about the coping, self-care, and the healing post-COVID, and the consequences included in the social, economic, mental, and social, spiritual aspect of all of this. Um, we've heard a lot about the COVID-19, what that has done, the impact it has had, particularly the disproportionate impact it has had on Black and Brown communities. And as we all know, it has certainly pulled back the curtain on those disparities that we already knew existed. But on top of that, what came with that was the toxic stress and the trauma and anxiety that was experienced or that is being experienced in communities of color, particularly with families and children. And how do we help them navigate through all of this to bring about a sense of healing? And I'm reminded of a quote that Jennifer Bailey made. She said that relationships are built at the speed of trust, and social change happens at the speed of relationships. And what I'm referencing here is the importance of relationships, or I should say, healthy, supported relationships in this whole process of healing. There's an African proverb that says, if you wish to go fast, go alone. But if you wish to go far, go together. And one of the things I looked at in as it relates to coping, self-care, and healing is the same strategies that we put in place for children who have experienced or who are dealing with ACEs, adverse childhood events or experiences, and how do we help them build resilience? And one of the key strategies is that children must have a loving, healthy, supported relationship with a adult in their life, be it a parent, be it a coach, be it a mentor, whatever it is. There's something to be said about healthy, supportive relationships in the process of healing and self-care. And so a lot of what we experience, not just with COVID, but with COVID bringing about the racial trauma that has been experienced, the barriers that are up, the things that prohibit us from moving forward and allowing us to be able to heal in the most appropriate ways, in the most healthier ways. So how do we get past the stress, the anxiety? How do we break down those barriers of racism? How do we dismantle the systemic problem we know is at the root of all that we're talking about? So in this, particularly as we move forward in our discussions, these are the kind of things I believe it's important for us to look at, and allowing ourselves to enter into some brave spaces and to be unapologetic about how we approach this and unapologetic about what we need to heal ourselves in this process. So I just want to share just a personal, very quick personal story with you that I hope that will help us frame our discussions for our breakout sessions. And I'm looking at this from a historical lens. And I believe that's very important, that the history is very important to help us understand how did we get here? And I remember a couple of years ago, my wife and I was traveling to North Carolina. And as we were driving through Halifax County in North Carolina, we drove through the back roads of Halifax County and right through cotton fields. And as I drove through those cotton fields, I began to feel a sense of anxiety, frustration, and anger And I reflected on the history. I reflected on the frustration and the anger that I felt. And that anger and frustration motivated me to want to share this story, to want to share about what even looking back, how that impact my life, how that impact my mind. And I felt it through my body. And in psychology, this is, when we think about stress, that physiological response connected to that external event, and then that anxiety that I felt, that cognitive element, and that physiological response, which really began to affect my body and my mind. I use that as a motivating factor to really share and help people understand what comes up for us as a Black and Brown communities as we're dealing with what we're dealing with today. How did we get where we are? And I believe that, again, relationships are built at the speed of trust. That historical aspect and reflecting on those things have really moved and motivated me to do more and to be more unapologetic in my approach. And I'm going to leave you with this quote from Langston Hughes. He says, "So here we stand on the edge of hell in Harlem and look out on the world and wonder what we're going to do in the face of what we remember." And that's before us. What are we going to do in the face of what we remember? And so as we consider this process of healing, this process of self-care and coping, what are we going to do in the face of what we remember? And so I want to challenge us as we go into our breakout rooms to consider this narrative. So again, as I share the instructions for the breakout rooms, they're going to be the same as before. Again, I just want to emphasize, you want to choose that person to scribe. You do have that 15 minutes to discuss and also submit that one action item to share with the larger groups. And so I want you to engage and, again, be unapologetic in your approach in this process. So now I guess we can go into our breakout rooms. Oh, there we go. All right, I was muted. Looks like we're all back together. And so let's just move on to our breakouts and have the person selected to scribe report out. So we're to use the same format as before. So group number one, the action item for the outcome of discussion that you've shared in your group.
I was in group one.
Okay.
We talked especially about language barriers, and every single thing we do from a health standpoint needs to be in the language understood by the individual. And also talked about all the barriers in very complicated insurance processes. And those two components, while seemingly basic, are incredibly complex and huge barriers. And we'd like to work on simplifying those.
Okay, great. Very important piece. Okay, group number two.
Hi, so yeah, we talked about having better education regarding bedside manners for healthcare professionals, including like empathy training and training in cultural manners. We also talked about having more Black and Latino healthcare professionals in various fields, so reaching them at middle school and high school, and then some advocacy skills training for patients.
Wonderful. It looks like you're taking a cultural humility approach.
Yes.
That's the word.
All right, wonderful. Thank you so much. Group number three.
We talked about the obstacles that people were facing in getting the information and getting access to vaccination. So things like transportation, because sites were not on the right side of town. People don't have cars. We also talked about the importance of communicating the right message to the right audience. So the way we communicated with senior citizens is not going to work with teenagers or 20 somethings. And we have to identify leaders, trusted leaders in the community that make this younger group that might appear invincible to COVID, or they might think they're invincible. We have to figure out how we can better connect with them to make them understand the seriousness of this. And another point that was made was we have to make sure that we're connecting with the right organizations. So whether it's a sorority, a fraternity, because having the topic at an event be healthcare alone might not be a strong enough hook to get the people we want to come there. So we can have healthcare as the topic and have an expert speaking on it, but we need to partner with the sororities, the fraternities, these other social organizations to get the people to come at least and listen and do that. So a lot of it was audience engagement and proper messaging.
All right, wonderful, wonderful. All right, next group, number 4.
Okay, so that's us. Our question was, what is needed for our communities to thrive post-COVID? And we discussed mental health and trauma and all the things that we've gone through. So beyond the illness and, and there's additional repercussions of that. And we talked about one of the barriers of healing is that we have been trained not to deal with our trauma because there's so much stuff going on. We keep our stuff inside. So we have to sit in our discomfort. And I know, Mr. Green, you stated, you made that comment. We have to sit on it and be uncomfortable to be able to deal with that. There's a quote here, which is, God can't heal what we don't reveal. And that's extremely powerful. And we have to seek support and work through our feelings and trauma. We have to invest in education. We talked about teaching about activated patients, right? People that will feel comfortable in participating in their own health, asking questions and working along the providers to have good health collectively.
All right, thank you. All right, next group.
Group 5, hi.
Group 5.
So our question was, what workforce barriers can you identify and potential solutions? So we actually gave 2 answers. We cheated a little bit, and they're seemingly unrelated, but so the first one is strengthening labor protections, because we saw a huge issue with lack of paid family leave and paid sick leave. Paid leave of any kind was a huge issue for folks. So that's pretty straightforward as a potential improvement. But then also we talked a lot about centralizing and or better coordinating information about general services, because as has already been said in this part of the conference, people often don't know where to go, or there's too many places to go and they're not sure, and it's just navigation on very simple things. So that doesn't on the surface seem like it's workforce specific, but as we know, or as a lot of us know, worker experience is, and quality of life is a huge issue. So important that it became the 4th aim, turned the triple aim to the quadruple aim. So that I feel like this speaks to that.
All right, thank you. All right, do we have another group?
Yes, group 6. We spoke about the inequities in healthcare. Some of the things that were talked about by the participants in the group were experiences in the past regarding pregnancy and interactions with nurses, where there was sometimes judgment based on the person's age and their insurances that they had, or lack of insurances. One of the other things we discussed was, when you don't have private insurance, sometimes you're bounced around if you're pregnant and you needed for healthcare, you don't get one specific healthcare worker that you work with. You could possibly be working with a variety of different healthcare workers. And then on one of the last points that we made by one of the participants, he brought up how in the keynote speaker's presentation, there was not a lot of information there for men discussing how they interact with the healthcare community. And that's because men don't usually talk. This was one of the comments that he made. So the action item that we talked about, he has a group and, just trying to work with men to explore more or take their wives with them or someone with them that can talk to the medical provider about what's going on or ask more questions about the supports they're receiving.
All right, thank you. Thank you so much. All right, is there group 7?
Yes, that's
Okay.
me. I was trying, I'm sorry, Dr. Earl Green. It's me. I was trying to find the unmute button and I'm like multitasking over here. So,
Okay.
I finally got this right. We are group 7. We have what racist and discriminatory structures and institutions should be addressed. How would you recommend addressing them? And for us, I just want to highlight a summary that we talked about education in all of the systems, from healthcare to public education institutions, but also work training and opportunities, and that being an ongoing thing, right? So not that we have a workshop or a training and that it happens and then there's nothing after that except for once a year. So it really has to be an intentional, ongoing conversation in all aspects of education, whether it's through a church, your community, your neighborhood, your healthcare system, your public school system, all of those things on a continuously basis. And I think my child is here to get me.
Can I add one more thing to group 6?
Sure.
Language barriers being an inequity as well. I missed that one. Sorry about that. That sometimes, depending on your language, or people may somehow think that you're less than and talk to you in certain ways or not talk to you enough. So making sure that there's a support that you have with you, it's going to be able to help you with that.
Wonderful. Thank you. Thank you so much. Is there another group? Okay, well, thank you all so much. And all that we've heard really speaks to the importance of working together, these trusting relationships, and going through this process. And I just want to leave you again with this, because I think this is very important, that if we wish to go fast, then we'll go alone. But if we wish to go far, we have to go together. And so I thank you all so much for your discussions. And again, your comments will be posted and we will continue this work. And thank you so much again for your work that you put into this. So I turn it now back over to Reverend Johnson.
Actually, I'm going to jump in.
Okay.
I am going to try this again because I am a believer in repetition. And it leads to learning and understanding. But I want to talk about the Faith in Medicine Award again. It is an award given annually in the name of Reverend Weldon Thomas, one of the champions of the link between health and the spirit. It's given to someone who has impacted the health of racial and ethnic minorities in the 9-county Finger Lakes region that is served by the African American and Latino Health Coalitions. Health professionals awarded this honor believe that health is impacted by spirituality and faith, and vice versa, and actively work in our community to impact both. This year's recipient embodies those principles, and she is the first to tell you that health is a spiritual matter. She is the Community Wellness Project Manager for Common Ground Health, the founder of the Interdenominational Health Ministry Coalition, and leads Renewing of the Mind, a mental health education training program. She is both an ordained minister and a registered nurse, and she is my dear friend and colleague, the Reverend Phyllis Jackson. And as you can see, the plaque reads, the Reverend Dr. Weldon Thomas Faith in Medicine Award, Reverend Phyllis Jackson, RN, 2021. When faith in God is put together with medical knowledge, disparities are erased. It is my distinct pleasure to award this honor to Reverend Phyllis Jackson and invite her to say a few words if she wishes.
Thank you so much. I am deeply humbled and speechless almost, which is rare for me.
Yes, it is.
But I do want to say that I am honored to accept this award. And Dr. Weldon Thomas was my dear friend, mentor, colleague, and we worked hand to hand for a long time. I am absolutely grateful and for all of you, because I don't do this work in a vacuum. I do this work with others. And as Reverend Green has said, it is those trusting relationships that have enabled me to do whatever little bit that I do. But it's us collectively that bring this to pass. And I am so grateful to God for each and every one of you and all that you do and all that you contribute to my life and the life of our community. So I just say thank you so much. I appreciate, I pray that I will continue to be able to be used by God in this role to help us eliminate health disparities, inequities, and bring health and wellness of mind, body, and spirit to all in our community across the board. Thank you so much, and I appreciate it.
Amen.
Reverend Jackson, to be awarded twice in a conference lets you know the depth of the love and respect that we all have for you. And wanted to make sure that you were able to hear the great words and looks of affection that are directed your way. And I cannot think of a better person who's more deserving for the work that you put together and helped us all to be better people. Thank you again.
Thank you so much, Reverend C. Brown Johnson.
So now, everyone, this is the last leg of our conference, and we only have a little time left before we have to say goodbye. And I'd ask that if you would direct your attention to the screen for a poll. And after we take this quick poll, we'll go back to try to close out the remaining moments of our work together. Really good. So thank you all for taking that poll. It's going to help to inform our work. As we listen to so much here today, it dawns on me that every great pandemic, every great crisis, every major issue requires us to ask three questions if we're going to get through it. We have to ask what, so what, and now what? We're grateful that our presenters have been dealing with a lot of the what. Wade Norwood talked to us and as usually educated our minds as well as spoke to our souls and helping us to understand the depth of the inequity and our opportunities for coming together. Dr. Kenyani Davis, she highlighted further these inequities and talked to us about the difference between the equality or inequality and inequity, and challenged us to come together and do great things together. Certainly Julio Jordan, we thank you, who said something interesting. He said to look at ourselves and ask ourselves, what have we done? And then Minister Green so powerfully spoke about our shared traumas among families, within families, and that we need healthy, supportive relationships if we are ever going to deal with this trauma that actually also lives inside of our bodies. We thank you all for giving us the what. We must also ask the question, so what? We have to face the fact that there are those who are not so easy to reach. There are those who will not get vaccinated because of a phone call. Those who won't advocate for better health care just because of a flyer. And so how do we reach the least of these? They are there, and for some reason, we're not putting in enough work yet to deal with that population. We have a lot of work to do to get to those in 14621 and 14605 and 14613 and 14611 and 14608, among others. There's a lot of work that we have to do, and it will take all of us going another mile, reaching out further, saying we will pull those off the couches to help. We will walk on street corners to help. We will knock on doors to help. We will stop by barbershops. We'll go into bars. We will go wherever we need to do to get the message out that we love even the least of these. Those who many have forgotten, we have not forgotten. That's our so what. But lastly, now what? We have to continue these conversations when we go back to our coalitions. And so we invite you to join one of our coalitions. If you're interested in learning more about our work and our work groups, including the African American Health Coalition, the Latino Health Coalition, or the New American Health Coalition, you can submit your interest using the form that should have just now been placed in the chat. We can use your help. The harvest is great, but the laborers unfortunately have been few. So please join with us that we may continue this great work until we can eradicate one more epidemic, one more pandemic. Thank you for that. And now I'll be joined by Diana Fernandez, co-chair of the Latino Health Coalition, as we share some closing remarks. Can we spotlight Dr. Fernandez? There she is. And so let us close in tandem in this way. Thank you for joining us this morning. We hope you have found it worthwhile. Healing will not happen overnight, but we commit that we are with you and the community for the long term to help us heal from the racism, discrimination, and health inequities that have scarred us.
Gracias por estar con nosotros esta mañana. Esperamos que sea valioso para ustedes. Sanarse no va a pasar de un día para otro. Nosotros nos comprometemos a estar con ustedes y toda la comunidad por un largo tiempo para poder sanarnos del racismo, de la discriminación y de las inequidades en salud que nos han herido tanto.
Next, we'd like to extend our thanks to our sponsors who have made it possible to present this event at no charge to participants. Our platinum sponsors, Wilmot Cancer Institute and Ibero-American Action League. Our gold sponsors, the Black Physicians Network and the University of Rochester, CTSI and Health Sciences. Our silver sponsors, NCADDRA, SEIU 1199, Excellus Blue Cross Blue Shield, Fidelis Care, Action for a Better Community, and Trillium Health, and also our bronze sponsors, Rochester Regional Health, Planned Parenthood of Western New York, CHWAR, the Monroe County Medical Society, and Helio Health.
Queremos agradecer también a todos nuestros sponsors que hicieron posible esta presentación, este encuentro gratis para todos nosotros. A los sponsors de platino como el Instituto de Cáncer Wilmot y la Liga de Acción Iberoamericana, los sponsors dorados como la Red de Médicos Negros y la Universidad de Rochester, CTSI, Health Sciences y the Greater Rochester Health Foundation. A los sponsors de plata como el NCADDA, CEIU 1199, Excellus Blue Cross Blue Shield, Fidelis Care, Action for a Better Community, and Trillium Health. Y los sponsors de bronce como Rochester Regional Health, Planned Parenthood of Western New York, CHWAR, the Monroe County Medical Society, and Helio Health.
And so now our 2021 meeting has come to an end. We are so very grateful that you were willing to share your time, your life experiences, your creativity with all of us. Our community and our nation need to heal not only from a virus that touched some more than others, but from a history of inequities. We believe that healing comes through action. We wish this conference has served as a time for collective and personal reflection, and that you leave the conference energized and with a sense of hope. We will see you next year, perhaps and hopefully in person. Again, thank you so much. Have a great rest of the weekend. You know how to find us. Be safe and be blessed.
Nuestro encuentro del 2021 ha llegado al final. Les agradecemos muchísimo que hayan querido compartir con nosotros su tiempo, sus experiencias de vida y su creatividad. Nuestra comunidad y este país necesita sanarse, necesita curarse, no solo de un virus que afectó a algunos más que otros, sino también de una historia de inequidades. Nosotros creemos que nos curamos a través de la acción. Esperamos que este encuentro haya servido como un momento de reflexión personal y colectiva y que dejen este encuentro energizados y con esperanza. Los veremos el año que viene. Esperamos que el año que viene sea en persona. Otra vez, muchísimas gracias. Que tengan un buen fin de semana y saben dónde estamos nosotros. Cuídense mucho.
Thank you all and good afternoon.
Gracias a todos.